We all heard the platitudes. Just focus on your sleep hygiene, get a balanced meal, go for a walk. When we talk about physician wellness, it's far too often framed as an individual resilience problem. But the reality, we are working within a system that has historically punished the very clinicians who need support the most. Today, we're cutting through the noise and tackling the systemic Today, we're cutting through the noise and tackling the systemic barriers to mental health in medicine. I'm joined by Dr. Stefanie Simmons, Chief Medical Officer of the Dr. Lorna Breen Foundation. And here we're discussing her journey through trauma, the tragic legacy of Dr. Lorna Breen, and the massive historic shifts we are finally seeing in state licensing and credentialing across the country. This isn't just about burnout. It's about dismantling the stigma that has kept us silent for far too long. If you're a clinician, this is the most important conversation you'll hear this year. And it's not isolated to just physicians only. Nurses, you need to hear this too. I'm Dr. Mark Papadakis, nobody particularly special, just another freaking ER doctor. And this is the JAFERDcast. Let's get on with it. All right, so I'm here with Dr. Stefanie Simmons. Thank you very much for joining me. Hello.
Thanks, Mark. I'm happy to be here with you today.
So, the Dr. Lorna Breen Foundation, this is something that I want to talk about for a little while now. I have brought up and invoked her name actually in a wellness talk I give to my residents. I started practicing as an attending in 2019, and then, of course, 2020, COVID hit.
Yes.
And wellness was a bit of a talk that I gave since then because ER especially, we're all pretty heavily affected. Tell me a little bit about you, first of all. What's your background, where you come from, things like that.
Yeah. I mean, it started when I was a small girl up in northern rural Michigan. We can go that far back. And I actually am going to start my story there because, I'm somewhat joking, but I really loved animals and I spent a lot of time out in nature and I thought I was going to be a vet, Mark. So
Wow. Okay.
it would be like the kid who would literally dissect the roadkill to see how it worked. And my dad was a hunter, so I would also section the lungs of the vet that he harvested and like look.
Wow.
I'm now a vegetarian, maybe related. You just
You must have gotten A's in anatomy, man, because
well,
that's pretty impressive.
I'll tell you, it was really interesting and I loved it. And then I went to school to be a history major because it turns out that I had this other great love, which was why things happen the way they do. And like in animals, that was the anatomy and physiology. But in history is how societies change, how people change, how decisions are made. And so I thought I was going to be a history professor and I went to school to do that. And there was this sort of alchemy that happened throughout the course of undergrad where I realized that these two loves that I had of knowing how things work sort of on a visceral, literally level in animals and people, and then knowing how things worked on this like societal and human level kind of came to a head together in medicine because we're dealing with people often in very momentous times for themselves and for sometimes for society. And we're having to bring to bear knowing how things work in order to intervene and to help that individual in that moment, allow them to go on and make the difference that they're going to make in their lives and as people. So I did end up going to medical school. I'm a lifer at University of Michigan. So undergrad, medical school, residency, matched originally in anesthesiology and then switched and also did a residency in emergency medicine.
Nice.
And that's where I started my career after my training.
Awesome. It's always interesting to hear people answer why they went into medicine because there are people who, like you, pivoted later in their professional career and their undergraduate career. And there are people who is like, well, I'm going to do into medicine and that's what I'm going to do no matter what. And I was one of those people. It took me longer to get there than others, but I always have no offense to some of my listeners out there because I know who you are. I always have better conversations with people who decide to pivot to medicine later after certain experiences, after certain different exposures. And I feel like if you're an undergraduate listening to this, if you are a history major or sociology major, you honestly, in some ways, stand a better chance to get into medical school than somebody going to just be biology. Because in many ways, those humanistic, the gen eds, as we used to call them, in college, help you become a better doctor. That's my opinion.
Well, I think I would always come to my patients with that sort of social science lens of the why. Like, why are you here? Not just
Mhm.
what is your diagnosis and what is my treatment plan, but why did you end up in the emergency department? Because
Right.
there's also a different story for the patient who comes to the emergency department with their abdominal pain than the person who goes to their primary care doctor with their abdominal pain, right? And part of that is acuity and intensity of symptoms, but part of that is social and sociologic. And so I actually love emergency medicine for that. Like, I love the procedures, I love the team dynamic. That's what drew me to emergency medicine. And to anesthesiology was the procedures and the birth to death and the critical care. But the reason I ended up in emergency medicine instead of anesthesiology was the social science aspects of emergency medicine. So I was doing my residency. I had actually decided I was going to do a Robert Wood Johnson Clinical Scholars Program and had gotten into that. Baby, my internship year,
Wow. That's tough.
you
That's tough.
know, it's really good that I had my kids when I was, like, ignorant of the impact right? But I had my first baby my internship year, and then I had a second child actually as a fourth-year resident, and that was a really pivotal point for me because of 2 things that happened right around the time I was finishing residency. So, the first thing was that I caught the worst case of my career,
Mm.
and it happens for everybody at some point. You have the case that's going to be the worst case of your career. For me, it just happened really early. It happened at the end of residency training when I was about to exit residency and go into this fellowship and my career. And this case is public record, so I can talk about it. I'm not violating confidentiality. But it was the middle of the night. The ambulance comes in with resuscitating a 3-year-old. And if you do the math, you will know that I had a 3-year-old at home
Huh?
at that point, and we did everything we could to try to get this kiddo back, and we failed. We could not resuscitate this child, which happens, right? And it's always bad. Like, nobody is unaffected by a pediatric death. But I wouldn't be telling you the story if that had been it. So what happened is that, like, about 6 weeks later, I got a summons to go testify in court because this child had been murdered. And so after I had cared for her, right, and couldn't get her back, I pivoted to take care of the patient that was left, right, which was her mother. And I comforted her and I explained what had happened. And I was also the mother of a 3-year-old. So I really identified with this woman. And the defendant in this murder trial was that woman, was this mother. And as you might imagine, that was really tough.
And we have no way of knowing these things, right? Unless they come in with police or something like that, we assume things happen. We don't really see the cause of this through the
Right.
emergency department lens here. So, wow.
So I was filled with rage, Mark, on behalf of my patient, right? This child, but also for me and for, like, all the children out there in the world and all the parents who lost their children, right? And what weren't the agents of that. And it's sort of at around the same time I developed peripartum depression. I was pregnant with the second child, and, like, we know now that, like, what is happening in your world outside of the pregnancy impacts your mood, and then that sort of, like, takes on a life of its own and gets accelerated,
100%.
all of the pregnancy hormones and everything. Throughout that year, I was moonlighting to pay for daycare for 2 kids, right? Like, working spouse, but it's hard when you're a young couple to make ends meet with 2 kids in daycare. So I was
And residency doesn't pay much. I'm just going to throw that out there.
That's right. Like, working extra shifts while pregnant, while having postpartum depression, while having a 3-year-old at home, and trying to reconcile all of these things together. And I chose wrongly at that point in my career not to seek help, not to get mental health care, not to even tell anyone outside of my spouse, my husband, that I was experiencing this, because I knew I was about to finish training. I was going to be applying for my first permanent license. I was going to be getting my first job. And everything that I had been told as a student, as a resident, was like, you don't want a mental health history on your record. You're going to be asked all kinds of places. It's going to impact your ability to get insurance, to get credentialed, right? So I didn't seek care. I didn't get a diagnosis. So when I tell
It
you,
can even impact your ability to get a medical license
oh yeah,
depending on the state you're in.
for sure. So that was the narrative that I had been told, and that was the belief that I had at the time. Part of our conversation, so if anyone's listening now and isn't listening near the end of our conversation,
Mhm.
I want them to hear now that I was wrong. Actually, at that point in time, the decision was the wrong decision. And now, even more so, it is much safer. And there has been a change, not only in the culture in medicine and how mental health care is viewed, but actually in the structure of licensing and credentialing. So I'm giving you the bottom line up front here of this discussion in case anybody leaves before they get to that. But at the
They
time,
don't leave. They listen to the entire conversation. That's right.
sometimes they're in their car, they're listening, Mark, and there's a car accident, right? Like that's the only
Yeah,
possible reason I could think why
that's
I did
right.
that. So I made that decision at that point, and let me tell you, that first 5 years of my career were rocky, 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 rocky. I dropped out of my fellowship. So I started it and I dropped out of it. And for people who don't know this fellowship, like it's kind of a big deal fellowship. It's very prestigious. It's hard to get into. So I decided like I just couldn't. I didn't have it in me. I started work at the community setting for our residency, which was a great hospital, great community hospital, great group, but not really the like academic hot chat trajectory that I had been on.
Yeah, you're not going to become the dean of medicine or something like that by going to this site. It's
Probably not. And what I would say is my opportunities were really awesome. It turns out it just different path. So what I did right out of residency is I worked part-time. I worked 10 shifts a month, which is not quite full-time. Didn't have any protected time outside of that. So my income was lower than it would have been. But I decided to decide to try what my hobbies were going to be at work. I sort of volunteered for a bunch of different parts of the hospital operations because I knew I wanted to do something, right? That wasn't clinical work. I loved clinical work, but I needed more. So while I was dealing with the sequelae of this postpartum depression and, everything that was part of that, I was also volunteering to be on the culture of safety committee, ironically, since I had this
hmm
safe to seek care. I was spinning up a therapeutic hypothermia program for the hospital. I was volunteering with the patient experience work at the hospital and like diving into figuring out the communication pieces between patients and clinicians. And you can see how like a lot of this is kind of relating back
right.
to these interests. So I did end up digging myself out of that pit. This did not end up being a long, like lifelong mood disorder, but definitely led to a rocky first 5 years to the extent that I even thought about leaving medicine altogether, right? Like after 12 years of training and like
Yeah.
hundreds of thousands
Yeah.
of dollars of right. Yeah.
And not for nothing, people think about how can you throw all that away? How can you throw all that education and training and money out the window? I mean, you sacrificed 12 years of your life to get to this point here. And now all of a sudden you're just going to what? Start from scratch? And people underestimate the psychological impact that medicine, especially this type of medicine, can have on the individual.
So it's pain, right? You're not leaving medicine because you don't want to work hard or it's too hard. It's actually too painful. And so I was still coming to work every day and showing up with a smile on my face and taking great care of
Oh,
patients.
of course. Yeah. Nobody, yeah. Somebody said the unhappiest people, the most depressed people are the ones who have a smile on their face.
Right. Right. And I will say like sort of doing a really great job.
Sure. Absolutely.
And so, but it was very, very painful because I had not developed the skill set to manage the
Mm.
traumas in what I was doing other than partitioning. And I was a grade A, number one, A plus partitioner. Like trauma, take it, put it in the backpack. Next trauma, take it, put it in the
Mhm.
backpack. Like I could go from a bad case to the next room and just like be there for the patient, do a great job. But I wasn't dealing with any of that. I wasn't processing it. I wasn't talking to anybody about it. There was not a culture of doing that. And so eventually that backpack gets just too heavy. And you're like a bug on your back with your hands and your feet up
Yeah.
there, right? And so I was given an offer by our chief medical officer of our medical group. The medical group that staffed that emergency department had about 900 doctors and staffed about 30 hospitals across the Midwest.
Wow.
And so I was given an offer to be the director of quality and safety for the medical group based on the work that I was doing. And I respectfully refused and said, there's nobody doing the work of patient and clinician experience for this
Mm.
group. I would like that job. And the CMO at the time said, I don't think that's a job. I don't know that. Can you write a job description about what that would entail? And
Sure.
so, I've had people point it out to me since then that why don't you write the job description and we'll see could have been interpreted as a blow off, but that is not how I interpreted it. Actually, this
Sure.
person was a very sincere mentor, a wonderful doctor. And so I took him at his word and wrote a job description with a point 0.3 FTE, like a
Mm.
third of a job, right? That
Mhm.
that they would pay me for, and I would do patient experience training, and I would coach people who were struggling with some task around communication or burnout, do some of the leadership development for the group, and I was given that job. So this was just a couple years out of residency. I have a job as the director of patient clinician experience for 900 docs. And it's very typical of physicians to experience something awful themselves and say, even before they've dealt with their own stuff, right? Even before they're fully through it, say, I want to take this experience and figure out how to help other people. That's exactly what I was doing.
Because that's what we're trained to. That's what we want to do. We want to help other people. That's why we go into this.
That's
So of course we're going to take our own personal experiences and say, "Oh, good. How can I make this better for somebody else?" And then forget about the person in the mirror.
that's right. So that's what I was doing. And I had a very hard one skill set over the next 10 years. I did not do coach training. I was like, I'm good at stuff. I could do this. Right. So, and there really wasn't there wasn't a big group of chief well-being officers. There, like, physician coaching was not the industry that it is today. There was patient experience stuff out there, but it was very like formulaic kind of, you sit down, you shake hands, you tell people how long it's going to be, you thank them, all that. That's not what I was interested in doing. I was interested in talking to doctors and PAs and NPs about why they wanted to take care of people and help them be a thought partner with them about getting back to a place where that's really what they wanted to do. And they wanted to put their
Mhm.
energy into that and do a great job. And to me, that's how you have a great patient experience, not following some formula.
Yeah, I call it cookbook medicine.
Yeah.
That's
Well, and
it's
customer
a
service, right? And customer service is important. If I call and make an appointment with my doctor, I want to get in to see them quickly. I want
right.
somebody who's polite and nice, and you want all of those parts to be smooth. You don't want to have to wait for an ultrasound 36 hours in the ER, because the
Correct.
process is gross. But the customer service is different than patient experience because I've had customers. I waited tables for 8 years. I was a great
Mhm.
waitress. I made great tips. I'm friendly. I can do all of the customer service stuff. I will do things for a patient that I would never do for a customer, right? I'm going to take care of a patient with an empty stomach and a full bladder and put their needs before mine, right?
Mhm.
And it's a very privileged relationship where they are telling me things they are only telling me that they may not have told their spouse, and
Yep.
I am holding that sacred in that relationship, and it's a very intimate relationship. I am touching their body in a physical relationship to help them, right, as their physician.
Mhm.
That is not something I would do for a customer.
Right, exactly.
That's not the relationship. So, it's a very, it has to be both. You have to have the customer service side of things, but you also need to be really connected to why you're a physician or a PA or a nurse practitioner caring for a patient,
And it's rough because as emergency physicians, we only have maybe 5 minutes to make that connection
right?
and get a patient to trust us and,
Yeah,
tell us, "Okay, why are you here?" "No, no, you told the nurse why you're here. Why are you really here?" And
right,
sometimes it manifests that they tell, the triage team one thing, they tell us something completely different.
right.
We come out and say, "Well, here's a workup." And the nurse is like, "What are you talking about? What are we doing?" And I said, "Well, they're actually here for this." "Well, they didn't tell me that." I'm like, "I
I
know."
know.
And sometimes that is the way it goes,
Yeah.
because the people who can establish that bond quickly are going to get to the root of the problem and figure out how to hopefully solve this. But it's tricky.
And it's a real skill set. So that's what I was helping people with in that role. And the history of my group over the next 10 years was the history of a lot of areas of emergency medicine, which was mergers and acquisitions, right? So that group that I
Yeah.
was working with acquired some other groups. And then, so there's some mergers and some acquisitions, and then got bought out by a very big group. And then that merged with another group. And bada bing, bada bang, right? Over the course of 10 years, now I'm doing that role as the vice president of patient and clinician experience for
Mm.
26,000 docs. So
Wow.
it was a very big national medical
Ooh.
group. Um, and I was trying to grow that support for clinicians um, in their journey as clinicians and as physicians, support them, build resources, um, and do that sort of in a very diffuse model where there was a lot of ability to influence, but really not a lot of authority over their environments, right? Because there's staffing an emergency department in a hospital that
Hmm.
has its own structures and its own processes and its own decisions.
Yep.
And so it was really like a lesson in how to lead without authority, how to influence environments, how to provide support where you don't like necessarily even employ the person, right? But you're trying to build these structures. So that's what I was doing in in 2020. That was my role. Along the way in 19, I stopped seeing patients. So I saw patients for about 15 years, and this role had grown and was very big and involved a lot of travel. Along the way, I had had my third child. So I had
Wow.
3 kids at home, an executive level position with travel responsibilities, and something had to give. It was a process it was an agonizing process of self-discovery and talking to my mentors and others who had sort of made that transition out of clinical practice. But I decided that whatever happened, the thing that gave could not be excellent patient care. And I was seeing few enough patients, working few enough shifts as I juggled all of these other priorities, that it felt to me like that was becoming a risk. Like it was becoming a risk that I wasn't going to be the person you wanted to see at the foot of the bed when you came in with a trauma anymore because I was doing it so part time. And so I made the hard decision to step away at that point from clinical medicine and to focus entirely on this sort of leadership of patient and clinician experience at this organization. Now, it turns out that October 2019 was a really weird time to leave emergency medicine because this, like 3 years later, it's the pandemic.
Right.
And at first, I thought I was going to step back in to practice clinically because we weren't going to have enough docs. But if, like, you remember back at that time, it's not that there weren't enough docs. Like, the work was really hard.
Hmm.
There was a lot of death. There
Yeah.
was a lot of risk, but it wasn't because there weren't enough people. We actually had decreased volumes across emergency
Correct.
departments across the country. So instead of stepping back into clinical medicine, I doubled down on mental health support, working with the clinicians who were dealing with all of that death and trauma and risk and societal upheaval, and really building out those supports. And then, of course, in 2020, that was when Lorna died and the foundation started.
Hmm.
So you asked me to tell me a little bit about myself, and you just got like a double handful, but that's the back.
Well, but here's the thing, because ultimately you're the face of this foundation. So, for disclosure purposes, you came to my hospital site, I talked about the foundation, talked about the services you have, and I thought it was important enough to get you onto this show because I thought more people needed to see it. Yes, you talk about the fact that we deal with death a lot in the year 2020 because of the pandemic. One of my friends who I graduated residency with went to work in a New York City hospital. And our doc, he would work overnights, and all he heard was the code blue alarm go off
Yeah.
all night long, constant. And it was at the time, March and April and May, even to June of that year, that he knew what was happening. He knew that those patients were going to cardiac arrest and they weren't getting better. They were dying. He would walk into work and he saw, and I saw too, refrigerated, basically trucks to house excess bodies the morgue couldn't house. The public saw it briefly and then later on forgot about it. We went from healthcare heroes to healthcare zeros. That's pretty much the sentiment among frontline acute care staff. It still is to this day in many of the people that I work with. And when I talk to the residents about wellness, the mantra of wellness is get a good rest, get a good night's sleep, drink water on shift, make sure you eat a balanced meal, go exercise. Tell that to a resident who's working 60 plus, 80 hours plus a week to do all that. Wellness is a lot of things, but it's not just taking care of yourself. You talk about taking care of yourself. How do you do that? Well, I like to go on bike rides. Great. What are you going to do in the wintertime? Well, I don't know. Or like, for example, you. I have many a resident, coworker and otherwise, who started a family in residency, who started a family in medical school.
Mhm.
And now they're juggling the career as a parent and a resident and all the responsibility that comes with it. Well, where's your downtime? So there's a lot of nuance to this conversation. Biggest one we'll focus on obviously is with Dr. Lorna Breen and the fact that, of all the things that happened, she committed suicide. That's where this whole discussion really stems from. So can you tell her story? I mean, obviously, like I said, you're the face. I'm going to have you tell this story because you're going to tell it better than I ever could.
Sure, sure. Thank you. So when you introduced me at the beginning of the of our conversation, as you mentioned, I'm the chief medical officer for the Dr. Lorna Breen Heroes Foundation. Dr. Lorna Breen, was also an emergency medicine physician. She was practicing emergency medicine at New York Presbyterian Allen Hospital in Manhattan, which is what she'd always wanted to do, was like practice emergency medicine in Manhattan, own a fast car and a black cat. And she had like, check. Um, she came back from vacation with her sister and brother-in-law and their kids to take care of patients in the first days of the pandemic. And she was taking care of patients, but she was also taking care of her community of clinicians because she was the medical director of the emergency department. So the people who were running those departments back then, were trying to figure out PPE for everybody, how to protect people, how to reduce risk, how to um, help cover the department when there were people whose kids were home from school, who didn't have daycare, there was nowhere to get them care, right? Like all of these issues and patient care. And so just day after day of these aren't 8-hour days, right? Like these are 18-hour days of trying to problem solve and take care of patients who are almost all dying and being at great personal risk yourself. So really tough situation. Now, I will tell you, a lot of people, when you ask them about those first few weeks of the pandemic, there's some horror about the experiences and certainly trauma, but also a real sense of like, this is what I trained for. And they were caring for people and doing what they could. And yes, there was a lot of human tragedies of people dying without their families there, and just a lot of that was really awful. And some of the bureaucracy and the administrative burden and like the BS around patient care went away.
Yes.
And so it wasn't all awful. There was a lot that was very satisfying, right? So that was the milieu that Dr. Lorna Breen was in. And she got COVID and she got real sick with it. But like many people did, 24 hours after her fever broke, she came back to that. And she went right back to those day after day after day, but she became exhausted. So physically, mentally, emotionally exhausted, unable to get up off of her chair in her apartment. And so her family actually called on her physician colleagues, her residency friends, her medical school friends, and they evacuated her by car to Virginia, which is where she grew up. And she received mental health care. And she was discharged, and she was explaining to her family that she was worried, like I had been worried at the beginning of my career, that because she had received mental health care, she was at risk of losing her license, her hospital credentials, certainly her leadership position, her role at the hospital. And that was one of the conversations that she had with her family before she died. And she did die by suicide. 12 hours after her death, the New York Times published an article about her. Her family had media trying to talk to them when all they wanted to do was grieve. But it's what happened next that really sparked the formation of the foundation and the work that we do now. So what happened next is that people started to reach out to her sister and brother-in-law, her family as well. And it was dozens at first, and then hundreds, and then ultimately thousands. So Lorna's little sister and her brother-in-law started the Dr. Lorna Breen Heroes Foundation to take them and to carry it into a movement where there is a place for conversations around professional well-being for healthcare workers. There is a way to address the barriers to mental health care that people seek. There is a way for organizations and individuals that are passionate and interested in this topic to gather and to have a community and to collaborate, and that there's a group that's advocating for healthcare workers. And so that's the Dr. Lorna Breen Heroes Foundation. And I'm so privileged to be able to work with them and for this foundation.
And in addition to obviously being a resource for physicians who need mental health resources, your foundation has actually scored legislative victories.
So really quite early on in March of 2022, there was the passage of the Dr. Lorna Breen Healthcare Provider Protection Act. And if you look at the picture of the signing ceremony, Lorna's sister and brother-in-law and mom and niece are there. The Lorna Breen Act was first of its kind federal legislation funding programs around professional well-being for healthcare workers. And that included direct grants to organizations and then also the Impact Wellbeing campaign, which was an action guide for healthcare leaders on how to start the work of professional well-being in hospitals and health systems. We also had the opportunity to partner with the CDC and NIOSH on the creation of that guide to be able to sort of spread the work. So the Lorna Breen Act was reauthorized this year, 2026, for 5 years for those life-saving programs to continue to receive funding and provide programmatic support for organizations around the country.
Now I'm going to show what you're talking about for the signing ceremony here.
Yeah. So that is March 18th, 2022. And behind President Biden, you'll see Corey and Jennifer Feist, Lorna's sister and brother-in-law. In the blue dresses, Lorna's mom, Rosemary, and to Corey's left is Charlotte, Lorna's niece, and to her left is Senator Tim Kaine. So he was one of the co-sponsors of this bill. The bill was bicameral, bipartisan. So it was Democrat and Republican sponsored in both the House and the Senate, and so was the reauthorization. So it was and remains deeply bipartisan, deeply human issue. So the original bill was passed by signed into law by President Biden, and the reauthorization was signed into law by President Trump. And we're currently going through the appropriations process right now. Throughout the process of the original bill and the reauthorization, it has been essential for health workers to raise their voices and share that this is important to them. And so there's been a grassroots effort, as well as organizations from across healthcare really lending their push to this work. And for your listeners, if they're interested in raising their voices in the appropriations process, we do have a link which I can give you for the show notes.
Yeah, the link is going to be in the description for both. If you're listening in the car, if you go onto the podcast website, it's going to be on there. It's also going to be on the YouTube description, so check down below.
Great. So that was, I think, one of the first sort of legislative actions and successes that came about. We also, that day, March 18th, now is Healthcare Workforce Wellbeing Day. So every year, we commemorate the signing of that act into law and celebrate healthcare workforce at large and act on their well-being. So we've also been working at the state level across the states to address licensing and credentialing, and that's really been one of the key areas of impact for the foundation.
This is this caught my attention because you spoke about this. So please, this is something that every healthcare worker should applaud here, because not just physicians, you're also working with nursing as well with this.
Nurses, dentists, pharmacists, and in a lot of states, we've been able to impact all licensed health workers. So I want everybody to know about this, because I think if you aren't in healthcare, you may not know about this part of things. So as licensed healthcare workers, and then for physicians and PAs and NPs as credentialed healthcare workers who care for patients in hospitals and health systems, as people who get malpractice insurance, who have to enroll for payers, meaning the insurance companies, to be able to reimburse for our work. We get asked the same set of questions multiple times throughout our career. And in the past, these used to be called the moral fitness questions. Like, are you an upstanding moral human being? Okay. And depending on how you define that and your belief system, you may agree that some of these questions are indeed about moral fitness, like, have you been convicted of a felony, right? Like, or are you a pedophile? We want to know that
Yeah.
to be
Good information to have.
good information to have, right? For somebody who's a health worker. And then there's the question that says, have you ever been diagnosed or treated for a mental health condition? And that stems back to a point in the medical understanding of mental health and the societal understanding of mental health, that there was a belief that this was a moral failing, that if you had a mental health condition, this was a moral failing, not a health condition, not something like my peripartum depression that is the combination of your internal biochemistry and your external events, right? But something that says something about you as a person. So, in a word, these were outdated. In a bunch more words, there had been a lot of people who had pointed out that they were outdated. The American Medical Association, the Federation of State Medical Boards, and the Federation of State Physician Health Programs had all said these questions are doing more harm than good. They are actually preventing people from receiving care that helps them be excellent health workers. And everything we know is that having a mental health condition actually does not, having a treated mental health condition does not prevent you from being an excellent healthcare worker. In fact,
Correct.
more people need to be treated for their mental health
Yes.
conditions that they have. And so there had already been a movement underway to educate the medical boards and to encourage them to change their questions. And the first year that we did a survey of the medical boards, we really said, yes, no. Are they asking these questions about mental health and substance use disorder, about diagnosis and treatment? Yes, no. Or are they only asking a single question about impairment for any reason?
Correct.
And if anybody ever wants to make a point of like, well, it's important to know about people's history so that we know if they're impaired now, I'll make this point about stigma. Nowhere were people asking, have you ever been diagnosed or treated for any medical condition? Because there are many chronic medical conditions that are potentially impairing. So I'll give you, for example, diabetes, right? When it is diagnosed and treated, typically there is no impairment. Right? You may have to check your blood sugars, watch your food intake. Maybe you would want the people around you to be aware of what high blood sugar looks like or low blood sugar looks like so they could help you if that happened. But we're not asking everybody what their hemoglobin A1C is. That's a measurement of your blood sugar over 3 months, right? And we're not asking people if they've ever been diagnosed with diabetes. Substance use disorder and mental health conditions are no different. They are chronic conditions that have the potential, if untreated or poorly treated, to become impairing. But we are asking about that.
Right.
And so what we're recommending with these questions is either you don't ask or you ask one question, which is, are you currently impaired for any reason? Or we're asking people to proactively attest to the fact that they're taking care of their business. Like
Right. Exactly.
they're getting care, right? And so the first time we did this survey of the medical licensing boards, there were 17 boards that were consistent with best practices. This was the reason at the beginning of my career why I didn't seek help, because I knew I was going to be asked that question. I am not somebody who would misrepresent on an application and say no, even if the answer was yes.
Right.
So I didn't want to have to answer yes, so I just didn't get care.
Because that could come back to burn you. If somebody does some digging, all of a sudden they want to ruin you. Here we are.
Right. Right. And so like you're faced with the choice. Do I not get care, which was my choice? Because by the way, the question isn't, are you seriously concerned that you might have a serious mental health condition that is impacting your life and happiness and choice? Like, no, it's, have you ever been diagnosed or treated for a mental health condition? So I'm like, oh, well, I could just brute force this and suffer.
Yeah.
Because at that point in my life, I was really well trained to suffer. I just got through residency.
But okay, so I'm going to tangent for 1 second because there's also this belief too that the people who need these resources are just not resilient.
Yeah.
Like we need to build like more resilient doctors, more resilient nurses. And that belief is not just outdated. Outdated is probably the best way to put it. Barbaric is probably another. The idea that the people who are burning out right now, we're not talking mental illness. We're talking about burnout and people are leaving the healthcare profession. The idea that, well, there's a lack of resilience.
Yeah.
Okay. And to tell people who've been caring for patients or in their worst moments of their lives that, well, you're just not resilient enough is I don't even think I can think of the appropriate word right now, is bullshit.
That's a great word. It's an appropriate word. I mean, I agree, right? I am I'm a very resilient person. I am an athlete. I am a physician. I'm a scholar. I am a researcher. I'm a parent. Like I was doing all of this caring for an infant pregnant and doing great, right? Like, operating really at a super high level. That was at my own expense. And we don't, give people I always say that, like, dealing with the traumatic experiences of caring for patients, it has to be an aerobic process.
Yep.
It needs, like, light and air and time, and what we do is we make it an anaerobic process. We try to do it in the dark, like, under pressure, and that's when it explodes. And so, yeah, we don't build systems that allow people to do what they need to do to be resilient. So this is really a systems issue, and we need to address the systems. And so that's what we started to do with the licensing is we said, okay, like there are 17 states that are best practice for physicians. Let's recognize them. So we made a badge, Wellbeing First Champions Challenge badge with our All In Coalition, which is made from organizations across healthcare and celebrated them. And with the badge, we made a map and we colored in the map with the states that were consistent with best practices. And so that became a change management strategy for education. If your state has the badge, communicate about the badge. Make sure people know the rules.
Mhm.
If your state doesn't have the badge, here's how you can get the badge. Here's the
Mhm.
recommended changes, which, by the way, we didn't make up the best practices. We took those from the AMA, from the Federation of State Medical Boards, from the Federation of State PHPs, from the researchers in this area over the years who had focused on this and had asked people what were the questions that would both protect patients and also allow healthcare workers to get healthcare.
Yeah, it's not coming out of a vacuum. This stuff is actually researched and quantified and everything.
That's right. So this wasn't like a de novo sort of discussion. So, but what we did is we used the change management techniques of measurement, recognition, celebration, education, made a toolkit on how to make
Mhm.
the change, and then offered free of charge review of any licensing application, any credentialing application, any malpractice
Wow.
application with recommendations on how to become consistent with those best practices. And then we have a badge, we have a certificate, we'll put you on the map, right? Like
Yep.
once you've gone through that process, we'll do the recognition part of things. We now have a map for physicians, for nurses, for pharmacists, for dentists in terms of their licensing, and also a map of the states where you can click on your state and see all of the entities, the
Mhm.
hospitals, health systems, clinics in that state that have also done the work for credentialing and peer reference forms. So when we started, there were 17 states for physician licensing. There are now over 43
Wow.
physician board licensing boards that have made these changes. And we're about to update our maps in May. So I'm not sure when this is coming out, but
Okay.
May 2026 we'll have our newest updates. We update them about 3 times a year, almost the same week, usually the same week that we update them, they're out of date because we are consistently churning on these applications and we have new sets of applications all the time from hospitals
Excellent.
and states. So this is the hospital that I was applying to for my first job and the state where I was getting licensed for my first job, I would now not be asked about my mental health history in either of those settings. So when I said at the top of our conversation that this landscape is changed, it is changing too, and it is changed. So the person in my position today does not have to be worried about getting asked those questions for their license or their hospital credentialing.
I think the way I want to end this show is obviously on that good note, but also a call for people to seek help.
Yeah.
Because it's one thing if you can say, hey, you are now no longer going to be afraid of losing your job, of losing your career, or not going into this career if you have a mental health issue. Substance abuse, whatever, depression, whatever it is, you can now do this job. The key now is, can you and can we change the culture of acknowledging this is not a resilience problem, that this is something that can be treated, that what you are feeling, if you work in healthcare, is normal.
Yeah.
And I need you to seek help now. You can seek help. There are pathways to do this now and to add your voice in now into this mix too.
I got to tell you, I was talking to Mel Herbert, who I know who Dr. Herbert is, but just like one of our superstar educators and leaders in emergency medicine. And I was having this conversation with him, and he said, "You know what else would solve this problem for people? If everyone checked the box yes, because we were all getting the help we need." And I was like,
I love it.
that is brilliant in the way that only he could have, been brilliant and put that. He's absolutely right.
Yep.
So I want to share one other finding that I think will put some of this into perspective too.
Please.
So we partnered with the Heart of Safety Coalition, which is a nonprofit that looks at all things safety in healthcare, and we surveyed groups of physicians, nurses, PAs, and NPs about perceived barriers to mental health care. And one question that we asked them was, are you worried that you'll be judged? Do you believe that you'll be judged negatively if you receive mental health care? Like 70% of people said yes.
Mhm.
Worried that I would be judged negatively if I received mental health care. And then we asked, if you had a colleague that received mental health care, would you judge them negatively for that? Only 10% of physicians would. And by the way, it's only 5% of nurses, PAs, and NPs.
Mhm.
So there's this mismatch between what we think is out there and how we believe. And so here's my takeaway. For people who are in that 10%, you're the problem.
Yeah.
Do some work on yourself.
Yeah. Mhm.
You actually need to understand that your colleagues, that people in healthcare deserve the right to receive healthcare, and that includes mental health care. And it is not an indicator that they are not a good physician, just like having diabetes would not be an indicator that they are not a good physician. So for those people who may hold that belief, I think it's worth examining that belief critically. And if you are in the group that is positive towards your colleagues that would receive mental health care, they're worried about you. They don't know what you believe. They're assuming the worst because we are
Mhm.
little c conservative beings who have a lot invested in being able to do our jobs. You need to declare yourself. And that could be declaring yourself by telling your story, by wearing a pin, by letting people know, like just as plainly as you can. I think that all healthcare workers should have access to mental health care. And if somebody I knew received mental health care, I would think that was a really great decision they made. So it's like anything, you need to declare your allyship, and you also, if you hold the view that's holding people back and hurting people, you need to examine that. But in those data, the stigma around mental health care is much more in the perception of the stigma
Mhm.
than the actual beliefs. And so I think there's a lot of hope too for where we're headed as a profession and as a society in the years to come.
I agree. I think there's a lot of change happening right now for the positive. And we talk about COVID-19, but COVID-19 was a huge inflection point in healthcare for a number of reasons. And we are starting to recognize it now. And to that 10%, to your point, I'll put even more bluntly, which is I'm pretty sure you have problems too. That I'm pretty sure that 10%, if you view somebody like that negatively, it's probably because you have a problem in your own personal life that you don't want to actually seek out and evaluate and have treated as well. So it's projection. Okay. But I am not as political as Stephanie is here. So take that for what it is.
Well, and really, I mean, what we want is for everybody to be healthy, right? And so if your beliefs are causing a problem for someone else, chances are they're causing a problem for you too.
Yes.
And maybe even for your family, right? And so we want people to be healthy. We want people to live an examined life and a healthy life. And ideally, this is never a situation where we have to be oppositional with each other, but to say, hey, how do we all get to a spot where people can be healthy and happy and heal others as well?
Exactly. So Dr. Stefanie Simmons, thank you so much for coming on to talk about this. It was a pleasure. And for you listening, again, there are going to be resources and links in the description below. Check them out. Check out what the Dr. Lorna Breen Foundation is doing. And if you find that your state is not on her beautiful map, contact your representatives, contact your state nursing, pharmacists, boards, everywhere, and make them aware of this. A lot of times it's an awareness issue. It's not a true, we don't want to do this type of issue. So education and empowerment is going to go a long way for something like this. And if you feel that you need to seek help, don't hesitate. If you don't want to reach out to one of these links and these resources that we have here, talk to somebody about it. I think you'll be surprised at the response that you get from a colleague or a friend if you admit, hey, I'm depressed, I have a substance abuse issue, I think that case went really wrong and I feel terrible about it. There's a range here, okay? Don't ignore those feelings, talk about them, and please seek help if you do think that you really truly need help because your patients, yes, they're counting on you, but so are your family and friends too. So Dr. Simmons, thank you again.
Yeah. Thanks, Mark. It's been a great conversation.
Thanks again to Dr. Stefanie Simmons for joining me. If you liked what you heard, please support this show by subscribing and giving a positive review wherever you manage to find us, either on Apple, YouTube, or Spotify. If you have questions, comments, or want to reach out for any reason, feel free to email us at JAFERDcast@gmail.com. This conversation wasn't just an interview, it was a call to action. Whether it's verifying your state stats and licensing map, or simply having the courage to declare your allyship to a struggling colleague, the change starts with us. We're moving from a culture out of silence and into support, but it requires each and every one of us to raise our voices. Please take a look at the resources linked in the description below. Educate yourself, check your state's licensing policies, and if you or a colleague need help, reach out to them. The system is changing because we are demanding it to change. Thanks for listening. We'll see you next time.